Parmasai is also an hemovigilance officer, a medical laboratory scientist, with specialization in epidemiology, background in public health. We shall be joined by is also the hemovigilance officer at Kenya Tissue and Transplant Authority, and Dr. Maturi. Dr. Maturi So I hope you are getting me. So I'll usher in Dr. Kresha Muyu to do the first presentation. Over to you, Dr. Kresha. Research Office, kindly give the rights to Dr. Kresha Muyu for her to do the presentation. Dr. Kresha, if you can hear me, kindly you can make your presentation.
Okay. We are back. Sorry about that. So I will go into it right away. As Chepkok said, my name is Gracia. We are in the Haemovigilance department at the Kenya Tissue and Transplant Authority. We have a series of webinars, re-engineering blood transfusion services for UHC. Haemovigilance is a very important part of the blood service. This is basically an introduction part of it. I would rightfully say that the meat is following, and would like to introduce this topic today, haemovigilance. And just to overview how our series would go, would introduce haemovigilance, the scope, the goal, the objectives, the players, and we'll talk about some adverse transfusion reactions and how to report. Just to introduce haemovigilance, it's a systematic surveillance of transfusion-related adverse events and reactions. It encompasses the entire transfusion chain from the donor to the recipient, and it's aimed at improving the safety of the transfusion process, and that's according to WHO. It is an integral part of the quality management in a blood system. It's very essential for continual improvement of the quality and safety of blood and blood products. And this is aimed to increase the safety, the efficacy, and the efficiency of blood transfusion. It's one thing to have enough quantities of blood and blood products, and it's another thing to ensure that they are safe and efficacious. So haemovigilance encompasses the monitoring, the reporting, investigation, and analysis of adverse events related to the donation, processing, transfusion of blood, and this is for purposes of taking actions to prevent their occurrence or recurrence. And why haemovigilance? Blood and blood components or products are integral parts of healthcare delivery. And we know that the transfusion process is multidisciplinary. All healthcare workers play a big part in the transfusion process. There's need that is greater than the production. You know that as a country, we've not been able to meet our demands for blood and blood products. It's therefore a scarce resource that should be managed and well appropriated. There's need to utilize it appropriately and rationally, and only when absolutely needed. So it carries also a myriad of risk factors. Blood can give you infections, you can get adverse drug reactions, and there's litigation associated with the use of blood and blood products. What's the scope of haemovigilance? It starts from donor, as I had indicated earlier. It's vein to vein, so it's from the donor, where we start by identifying safe blood donor pools. There is the donor screening to prevent undesirable effects of donation of blood. There's donor notification and linkage to care. And we are all aware, the ones in the blood ecosystem, that we test our blood for HIV, syphilis, hepatitis B and C. Blood and blood products and their utilization also forms the scope of haemovigilance, the use of blood components and their appropriateness, diagnosis of recipients and proper indications for blood, transfusion. We have a manual that has appropriate use of blood and blood products in our website. So we give blood only when blood is indicated. Blood safety is also part of Haemovigilance, where there's surveillance of infectious disease markers in donors. There's surveillance of donor exclusion factors. Not all the volunteers who come to donate blood actually donate blood, and it's because we have a criteria for surveillance of the donors, and we have reasons as to why we would defer a donor. Some would be forever, a donor would be deferred forever. Others is just for a period of time, and then the donor would be able to donate in future. Then we have the recipients, those are the clients. And then there's identification of transfusion transmissible infections, a traceback and lookback activity. We need to match our recipient database with reportable disease databases. When a blood unit is donated, it is labeled and marked and can be traced from all the way from the donor to the recipient. If there's anything that needs to be looked back and traced, including reportable disease databases, that one the system is able to do using the DAMU KE, and that is part of Haemovigilance. And then surveillance of adverse transfusion events and identification of long-term effects of transfusion. Transfusion doesn't just end when the patient gets the blood. Those patients are observed even 6 months to 1 year after they get the blood, just for surveillance purposes. This is the scope. It's vein-to-vein haemovigilance. This is in form of a diagram. And it starts all the way from recruitment and screening of the blood donors to the sharing, embedding of learning, what we get to learn from the whole system. So from recruitment and screening of blood donors, we have a donor questionnaire that we administer. There's a criteria for who is to donate blood, who is to be deferred, and who cannot donate blood. We have the age limits, 16 to 65. We have the weights that we need to use as we recruit and screen our blood donors. You're subjected to questions that will then identify you as a proper or a safe donor. Then there's the donor care and the management of any adverse events. Donors are monitored for any adverse events that occur after they donate blood. There's replacement of what they have given in form of maybe a soda or water, because you don't want that donor to collapse after they've given you a pint of blood. There's the collection of blood itself, and there's the phlebotomy skills that the people who go out there to collect blood need to have. There is the mandatory and the discretionary testing that I have talked about. Of course, the transfusion transmissible infections have to be screened. There's the processing and the storage within the blood service. This speaks to the good storage distribution practices. Blood is a cold chain. Blood and blood products, those are cold chain products. Getting the blood is one thing, and retaining the cold chain is another. So we have a cold chain management of blood and blood products manual, also that the KTTA has in the website, that has all these storage with requirements. Different products have different storage requirements. For example, whole blood will have to be stored at between 4 plus minus 2 degrees centigrade. Packed red cells, the same. Platelets, we can store at room temperature, 22 plus -2. And so on and so forth. Cryoprecipitates can be stored at -25 degrees centigrade. From the storage, then you go now to the storage in the hospital. This was storage at maybe the blood collection center. Then you would need to transport this blood from the collection centers or the regional centers, or maybe from a hospital to another. Then you would need to store it in your, maybe the blood transfusion unit in the hospital, in the lab. There are storage requirements. And then comes the clinical decision to transfuse. Not everybody needs to be given blood. There are indications for transfusion. For example, iron deficiency, the first line would be oral iron. For the ones who cannot tolerate oral iron, then we go to parenteral iron. So in short, the decision to transfuse is a careful consideration of expected benefits and potential risks. Then we go to the sample taking from patient and the blood orders. There's the sample testing in the laboratory. Then the blood product would be issued. There's collection of blood and delivery to the patient bedside. And then there's the administration of the blood product, the transfusion process itself. Now, in the blood ecosystem, we have the 30-minute rule. Between the time you get the blood from the lab and the time you administer the blood to the patient. We know about the process of administering. We know about how we monitor. First 15 minutes, you're able to tell if this patient is going to tolerate this blood product or not. The next 30 minutes, you monitor this patient closely, and then monitor and evaluate patient for any response. And if there are any reactions, we are supposed to stop the transfusion and manage symptomatically the patient or the client. There is then the post-transfusion management of the patient. After the patient gets the blood, then there's the post-transfusion management of the patient. We have then the haemovigilance reporting following adverse events or reactions. We'll touch a bit on the reactions that are associated with the blood and blood products. But again, these will also be discussed comprehensively in our successive sessions. Each reaction has their symptomatology and also their management. Then we have the incident investigations as appropriate. An incident would be maybe a near miss where a patient would get blood when they don't need blood, or maybe a patient's blood is wrongly labeled. And then now we need to share and learn from this vein-to-vein haemovigilance in this form of activities as they follow each other. And what is the goal of haemovigilance? Why haemovigilance? Haemovigilance ensures continuous quality improvement of the transfusion chain. And this is through corrective and preventive actions to improve the donor and the patient safety. We also aim to improve transfusion appropriateness and reduce wastage. I have talked about appropriate and rational use of blood and blood products. And this is haemovigilance, since we reduce wastage. And if someone can benefit from hematinics, why then subject them to transfusion, which is also not a very cheap process? And we have also agreed that it is a limited resource. At its core, haemovigilance systems resemble any continuous quality improvement cycle. We have heard of the PDCA cycle, a plan, do, check, act. So haemovigilance is just like any other continuous quality improvement cycle should be embedded into every step of the transfusion chain. So as your donor selection and recruitment, you plan, you do, you check, you act. As you continuously improve the quality of the transfusion cycle. And this is done to prevent errors from occurring in the first place. And since human is to error, if they occur, we take the corrective action. For this purpose, issues such as inadequate blood supply, structure, insufficient blood supply, increased need, unequal distribution, weak quality systems, risks of infection transmitted by transfusion, inappropriate use of blood and blood products are priorities in ensuring blood transfusion safety. And when we do this, the ultimate goal of Haemovigilance system would be to improve the safety of blood transfusion. Remember, we have alluded to the fact that getting the supplies is one thing, and ensuring that it's safe for our patients is another. And what Haemovigilance does is to ensure it's a continuous quality improvement, and then as we achieve improved safety of the blood transfusion. The objectives of Haemovigilance would be to promote blood safety and the prevention of adverse events, to identify weak, underperforming areas of transfusion. If we realize that it is training, it is maybe we have a gap in clinicians even knowing what is available as blood and blood products, components, would be prudent through Haemovigilance to at least train them, tell them what is available as a component, when to use each component, and when you can use alternative methods to maybe raise the hemoglobin of a client. To ensure safe and efficient use of blood and blood products, what I have just alluded to maintain awareness of transfusion adverse events, just to inform us that we are able to do the donor adverse events very well. We have a system called DAMU-KE that we use, and we have taken care of the donor. We are able to monitor the donor adverse events. But for transfusion adverse events, we've not had any reports. We have nothing to report. I don't know, there's lack of reporting on the side of the transfusing facilities. Would really encourage from the HTTA, from the blood service, will really plead and encourage us to report all our adverse events during transfusion, for us to know where the gaps are, whether we need to train on appropriate use on the transfusion process itself, or whatever, maybe just a skill, or maybe sometimes you find patient is getting transfused and it's the same bloodline that's being used to maybe give the antibiotic, and this is discouraged because you will not be able to establish whether an adverse event is primarily due to the medicine or the blood and the blood component. Others will react, of course. There would be reactions between maybe the blood and maybe the ringer's lactate that you're giving, the citrate in it. And then also to provide a method for documenting and investigating transfusion reactions. Are there any benefits of Haemovigilance to the blood donor? Of course, yes. There's improved donor safety with a reduction in the frequency and severity of donor complications. There's greater confidence in the blood donation process. So if you take care of the donor, you will have greater confidence in the blood donation process. You will get more donors coming in to donate blood. The WHO requires that we get voluntary, non-remunerated donors but this has not been the case. Mostly we are getting blood from replacement donation, which is not the way to go for a blood service. So if you have a proper hemovigilance, then you improve the donor confidence, and you get more volunteers, and you get more regular and repeat donors. To the blood transfusion service, there is improved donor retention, what I am talking about. There is early detection of deficiencies and weaknesses. There is continuous improvement in the quality of the services and the products. There is improved public confidence and trust in the blood transfusion service system. Because you're continually improving the system, you're continually correcting and making the services better. To the healthcare facility, there is systematic and consistent reporting of all adverse events, which is where we really wish to be. There is development of skills and expertise in the area of total quality management. There's reduction in adverse events and better healthcare outcomes. And of course, there will be less medical legal action with an overall improvement of the community's regard to a particular facility. To the blood recipients, to the patients, there is improved health. There is reduced risk of harm due to adverse events. There will be greater confidence in the blood transfusion and the blood products and components transfusion, and there's improved public confidence and trust in the blood transfusion service system, just like any other programs. To the physicians and other healthcare workers, imagine there will be identification and mitigation of transfusion-associated risks, identification and quantification of unavoidable complications, and you'll get feedback leading to improved practice. To the region, the national health authorities, the regulatory bodies, there will be early detection of emerging pathogens and the implementation of measures to mitigate the risks. There will be identification in trends in adverse events and opportunity for timely corrective action. So if we report these adverse events to the PPB, they are able to give us signals, they are able to direct us and give us trends early enough for us to timely corrective action. If the testing services detect that there's an emerging pathogen, then this would inform the public health programs, the HIV, malaria, and there will be implementation of measures to mitigate the risks before it gets out of hand. And who are the key stakeholders? We are all stakeholders in this. The regulatory bodies, the KMPDC, the KNH-UoN, the PPB, the Nursing Council, the Clinician Council, the KMLTTB, we are all key stakeholders in ensuring that hemovigilance is attained, is achieved. The county health services, we have our blood satellites in the counties. We cannot do this without the counties. So we really hold the counties big partners and stakeholders in this. The transfusing facilities, we cannot be talking about hemovigilance without our transfusing facilities. All our blood establishments, the blood transfusion service itself, blood donors, the recipients. We have technical working groups around hemovigilance, hospital transfusion committees, and the community at large. I just repeat that all of us have a responsibility. Hospital transfusion committees are based in the hospitals, and those are like actually what determines how blood is used in our facility. It is our wish and our prayer and our vision that all transfusing facilities have hospital transfusion committees. I will talk a lot about this, but this will be handled by our next speaker, Hilary Barmasai. Hospital transfusion committees. We cannot talk hemovigilance without mentioning hospital transfusion committees. Allow me to mention the transfusion reactions. Also, as this will be discussed in detail in our successive CMEs, but just allow me to mention that transfusion reactions can be classified as acute or delayed. Acute within 24 hours, delayed after 24 hours. Remember this, the patients, even 1 year patient can come back with a delayed transfusion reaction. So it's an interesting place for a cohort event monitoring studies where you can walk along with patients who've received blood and blood products and see how they turn out, or if they develop anything, just for continuous improvement. So under acute, we have can further be subdivided into immunologic and non-immunologic. Under immunologic, we have the hemolytic, the febrile non-hemolytic, can have allergic reactions, and then the transfusion-related acute lung injury. All these transfusion reactions have some symptomatology associated, specific symptomatology associated with each of them. Under the non-immunologic, then we have bacterial contamination, circulatory overload, and physical chemical hemolysis. And the same as the delayed immunologic and non-immunologic. These ones after 24 hours and even up to even a year, you can have patients getting transfusion-associated graft versus host disease, post-transfusion purpura, transfusion-induced hemosiderosis, or even disease transmission, whereby you can have patients getting even the TTIs that we usually seek to exclude before we transmit the blood. And there may be the HIV, you can have even malaria, you can have the Zika virus, you can have hepatitis B, C, syphilis, and so on and so forth. What would cause some of these reactions? Some of the reasons, but not limited to this, may be errors in the collection and testing of blood samples. That's why we talked about donor hemovigilance, very important, selection, identification, testing of these blood samples. That's why we insist that if you're collecting blood, then we have to ensure that that blood is tested in our labs. All our satellites are channeled to our regions to ensure that this blood is tested and it's safe for our patients to use. And the rapid tests are highly discouraged, actually should not be used at all. Errors in the identification of the patients, in places where maybe they
Hello, can you hear? Can you hear us? Can you hear us? It's the audio. So they can hear.
Yes.
I lost it. Okay, we can continue. Just give us a few minutes.
Good afternoon. I don't know if you are able to hear us, please. Thank you. So sorry, we had some technical issue with our system. We are still making some corrections. But if you are hearing what I'm saying, I think we'll continue because time is far much gone and we still have a lot to do. My name is Hilary Barmasai. I'm standing in for Chepko Kibrono, who is addressing the issue of this technical issue. So we are going to continue, and I believe all of you are hearing us from this end.
Allow me to finish from where I was thrown out. I don't know at what point you lost me. We had gone through the management. And I think I was at my last one. We were talking about how to report. Said all transfusion reactions should be reported to the blood bank. And the remnant contents of the blood and the component bag should be sent for all the reactions. Because transfusion recipient samples and urine samples also need to be submitted for investigation. We were saying that if you're not able to report at the PPB website that has the adverse transfusion reaction form, which was the latest entrant into to make the 6 forms, email us the form, the adverse transfusion reaction form. All the transfusing facilities have a booklet from the Kenya National Blood Transfusion Services that has the adverse transfusion reaction form
email us at haemovigilance@ktta.go.ke. Remind your clients that they can use a USSD code *271# to report any reactions. That's if the clients maybe are discharged and they get any side effects or adverse transfusion reactions, kindly let them report. And to finish, I will just need to tell us that we need not be certain. You don't have to be sure. The imputability tests will be done and there will be a determination of whether a reaction was caused by the blood or the blood component. It's not up to you. You just need to be suspicious and report all the suspected events, the incidences, the errors, the poor quality health products and technologies. Remember, in the blood ecosystem, we have apart from the blood and the blood products, we have the blood bags, we have the reagents, we have all the consumables that we use in the blood ecosystem. So reports all suspected events, incidences, and errors. Poor quality HPTs to us, either PPB or Haemovigilance reports at ktta.go.ke. Thank you for listening to me and apologies for the network hiccups. Thank you. I'd like to invite Hilary Barmasai, who will take up the next part because I think we've lost a lot of time. Thank you.
Well, again, thank you very much, Dr. Krashamui, for that very nice presentation, very clear. I want to take this opportunity to present my slides. And it's now 3:05, and this is actually the time for QA, but kindly allow me to make my presentation briefly, and maybe we will reschedule for another day. So thank you. Let me share my screen. And I believe all of you can see my screen. Thank you. So I'm going to talk briefly on introduction to Haemovigilance. This is the second series. We had the first edition last year. And today, specifically, we are going to speak about the tools that we are going to use in Haemovigilance. So first and foremost, I want to state that transfusion service is a complex process. Just like in that picture, there are a lot of processes going on until we achieve what we want. And that if one of the process stalls, it's likely that there will be a jam in the system. And some at times it could be detrimental to our lives. So as my colleague said, this is monitoring vein to vein. But again, it's not that general. It is detailed that we need to check all processes in the transfusion chain. So it's a series of chains interlinked until we get the final result. So from these chains, as you can see, at every point of linkage, that is our point of concern. That is where we have our Haemovigilance monitoring at those places. So the rationale of Haemovigilance is actually when we do proper donor selection, donor phlebotomy, donor care, and also we procure quality equipment which has been calibrated well, and good reagents, and prepare good components. Then at the end of it, we have safe product. And on the process, when we do a good phlebotomy, that is on the side of the donor, and after blood donation, that blood goes to the ward, and it has to be prescribed well. Patient sample identification should be done well, cross-match, blood transfusion, and follow-up. All those will give us a safe process. Now, direct to the tools, we have quite a number of tools that we use in documentation of Haemovigilance. The first one is the blood donor questionnaire. This is normally at the point of blood collection. This is administered to potential donors before they donate blood to ascertain their eligibility. In that questionnaire again, we have a place to record our donor at first reaction. In case our donor reacts, we record and we manage accordingly. The second tool is the clinic laboratory register. This is used in the blood banks, as we normally say, or collection center and screening place for grouping and also documentation of grouping and screening results. We have the third one as the component register, which is used in the component preparation room to indicate the type of component prepared, the quantities, expiries, personnel doing it, and the quantities that are available in that blood bank. We have the blood requisition form, which is in the ward. It is used to request blood from the blood transfusion unit or the laboratory within that facility. And it contains the patient information and the type of blood component that is being requested and the person requesting that blood component. Then we have the blood request issue forger. This one is used by the hospitals to go and request the blood from a collection site. And this is specifically for accountability and traceability. And okay, so thank you. So we also have the laboratory cross-match register, which is used in the lab to document all cross-matches that have been done. We have a form called cross-match compatibility form, which is attached to a cross-matched unit, ready to be transported to the ward. Initially, in some hospitals, there used to be a paperwork written on top of that form, but this one is now one which is uniform to be used in all our transfusing facilities. We have the ward register, which is also used to document cross-matched units received from the laboratory. Then we have the blood transfusion observation chart, and this is the form that is used to monitor progress of transfusion during administration of blood in the ward. We have the adverse reaction form, which is used for documenting adverse reaction, and it also has some report on investigations done. Apart from those tools, we have our summary tools. We have the transfusion facility reporting tool, and which is done monthly at the transfusing facility. Then it is relayed to the county blood transfusion coordinators in all counties, also known as CPTCs, of which they will summarize for the whole county, then relay to our KTTA room. Remember, we are deploying the DAMO-KE platform, whereby we'll be receiving our digital reports through that system. I'm not going to show you much on how that is just a dashboard of the DAMO-KE, but this will be for another day. These are some of the reports from the system. And this is actually post-donation. And these are reactions from the donor side. These are for November 22. On the left-hand side, we have all the regions. Those are the 6 regional blood banks in the country. And on top, we have the types of adverse reactions and the numbers. For your information, initially, the numbers were large, but KTTA is doing much, though I'm not saying that is the place to be. Now, direct to the roles of HTCs, as my colleague said, HTCs, these are hospital transfusion committees, play a key role in reporting of adverse reactions, not only reporting, but also investigations. And they also take part in implementation of the national guidelines. Last year, we launched quite a number of guidelines. We have the Kenya policy on donation, transfusion, and transplant of human-derived medical products, intergovernmental framework on coordination of blood transfusion services, Haemovigilance manual, standards for setting up blood establishment in Kenya, Kenya national standards for blood transfusion services. So all those are available, and it is the work of HTC, it is the role to implement. They are also supposed to implement appropriate use of blood and blood products. So during their meetings, during their discussions, they will know which products are not being consumed and the reasons why, which ones are on high demand, so that they can guide the blood banks when they are preparing those blood components. They are also the ones to ensure that as components of blood are used as opposed to HTC's role is to monitor, report, discuss on the same. HTCs disseminate transfusion-related information. In case, like now, we have the new edition of the guidelines, it is the HTC who, to inform the clinicians and other stakeholders on the changes. Now, concerning the adverse events, so manually, so that they can discuss of clinical audits, blood bank, education and training, hospital engineer, driver and records. But then, this is subject to the nature of the hospital. Some hospitals or transfusion facilities are small, but again, that does not mean that we should not have a committee to address issues of blood. So depending on the size of the committee, you should be proportional. Now, from our experience from KTTA, there's been challenges facing facility transfusion committees, and some of them are one, startup process. Most of the facilities fail to start up because one, they don't have information, they have not been sensitized on haemovigilance, so they don't prioritize as a matter of importance in their activities. We also lack of quorum in the meetings. There are many activities in our hospitals, transfusion facilities, and that most of the key focal people attend to those meetings. So sometimes they may fail to really attend the FTC's meetings. High staff turnover. In most hospitals, there are normally, especially the government, there are transfers, which are sometimes frequent. And so you choose your, you elect, establish a committee today, and in some few months, those officers are transferred, and so FTC dies naturally. We also have lack of staff self-motivation. Initially, when we had a donor from those PEFA, University of Maryland, they used to support those FTCs by giving them some incentives, maybe in the form of teas or lunches. And that, so in that connection, they was motivated to remain actively in the FTC. And also, lack of clear feedback mechanism. So sometimes FTCs address issues, they escalate the reports, but again, at times from the Ministry of Health or the relevant stakeholders and authorities, they fail to get the feedback. So sometimes they get discouraged and the FTC stagnates. In other occasions, there's some management which are unsupportive because the officers standing in the FTC sometimes should be allocated some time as per their schedule, but some management maybe may not be willing to provide some time. Occasionally, there's been insufficient tools for reporting, and that's why FTCs also fail to report in accurately and timely. Now, there are some strategies to address the challenges in formation of FTCs, and I will just talk about one because of time. So the challenge of starting up. So what needs to be done is to a sensitization of HMTs and heads of departments. So they should know the importance, why there is need for these committees in our system. And then there should be selection of the HTC members, and also involvement of the hospital management, as I said, so that they can also prioritize and also give some resources to this committee. And the committee should have clear agenda and terms of reference to guide them during their activities. So they should have some goals, and also they should have some work plans. They should also have a schedule of meetings. They should also use or develop SOPs and also utilize the guidelines. So briefly on the transfusion, facility transfusion committees in Kenya, this is data for December 2022. We had only 91, that is just last year, 91 facility transfusion committees. And I think, as my colleague said, this could be one of the factors that most facilities are not reporting. And that as at now, KTTA is working towards mapping all the transfusion facilities in the county as we prepare to go for inspection and support those facilities. In conclusion, transfusion reactions are mostly due to chronic errors and can range from benign to life-threatening emergencies. So it should be taken keenly that blood transfusion is a high-risk process. And so Haemovigilance plays a key role in early detection, discontinuation of transfusion, and supportive care to the key key to the management of the concern, that is patient or recipient from the other side. So reporting of all reactions helps to improve standard practices and reduce future occurrences. However, in the past, there's been most of the officers have not been able to report because of fear of punitive measures. But again, I want to state clearly that this reporting is for improvement in our practices so that we save as many lives as possible. So indication of blood transfusion must be very strict. Now that it is a high-risk process, the authorized people should be the only ones to really prescribe for blood transfusion. Also, donors, the patients must be consent should consent on the process because that is part of ethics. And all activities in transfusion should be audited. Vigilance is mandatory. There is no way our processes will be okay without vigilance, and compliance should be or must be 100%. So thank you very much for that brief presentation. There are some tools, and I don't know, Dr. Grasha, you will be able to project them because of time. We have tools, we have the advanced donor reaction. I believe, is it shared? Are you seeing? Yes, so that is our advanced transfusion reaction form. So these are just some few selected tools for us to see and appreciate that they are very important. These are the ones for documenting any donor reaction, and it has the patient information, reaction information. We have the component, the type of component that might have caused the reaction, and what should be done. That is after reaction, which specimen should be collected and where should they be taken to for what purpose. And then now the report should be very clear and that and to be sent to the HTC for documentation and further discussions. So basically, we also have some other tools, but I will reserve that for another day. So at this juncture, let me say thank you very much for listening. And as I said earlier on, Chepkok is not around. I'm going to take this time to welcome our panelists to say something, and then we'll continue. So allow me to request Dr. Peter Maturi. All right, thank you. I'm not seeing Maturi, but Rukia Koryo, kindly you are welcome to make your comments.
Thank you, colleagues, for that wonderful presentation. So I was just answering some of the questions on the chat box, and I can see we have several hands also. So basically, my colleagues have covered what haemovigilance is and what, as a country, we aim to move forward to, so that we may provide safe blood to all of our patients. And as we said, haemovigilance is basically something that is for everyone. It starts from the donor all the way to the recipient, but everyone is involved. My senior colleague, Dr. Maturi, I'm not sure if he's in the room. However, with my limited knowledge, I may be able to address some of the concerns. So the first one was I can see a question here from Nida Okumu. Why are carriers of sickle cell discouraged from donating blood? I mean those with HbAs on electrophoresis. So according to CDC, carriers of sickle cell are not discouraged from donating blood. Remember, these ones have the trait only. They are not sickle cell disease patients. So they do not pose a risk to both the recipient and the donor. Okay, I'm scrolling fast because we are way behind schedule. Okay. Okay, my colleague will take the one for antibiotics. Kindly discuss on antibiotics and septicemia and how it relates to transfusion reactions.
Is it
Where is it?
If the patient has is on antibiotics, if the donor is on antibiotics, kindly discuss on antibiotics and septicemia and how it relates to transfusion reactions. So is it related to the donor, to the recipient? So this is a direct deferral for the donor if you're on antibiotics, at least for 10 days until you finish taking your antibiotic. Thank you. If I get your question.
Thank you very much. Some other questions we have, are there synthetic blood products in case of donor shortage? So if I can attempt to that question is yes, we have some forms of cryoprecipitates which are found in the market, but not the whole blood. But we can have the products, but not the whole blood. The next question is, how can you, okay, it's running fast. Is there an electronic database for blood donors? We should not be carrying donor cards, okay? So, well, as I think that one has been answered. We have the DAMO-KE, on that it is still under deployment, but once it is fully deployed, all the information you will get from the system, from your blood group. You can even print your donor cards from the system. How often is blood supposed to be, okay. So how often is blood supposed to be given? Okay, I don't understand. I don't know if it is the interval between blood donations, but if it is donations, males can donate blood after every 3 months, but females can donate after every 4 months. Yeah.
Okay, I can see another question. Are donors tested before donation of blood? Yes, they are. We usually screen for transfusion transmissible infections, that is HIV, hepatitis B, and syphilis. And we do not aim to do rapid tests. And if this is a practice, we strongly encourage you to stop that practice.
About post-transfusion tests, how many cases of transfusion reactions are reported daily, considering that transfusions are ongoing 24/7? If any transfusion reactions is reported, what are the investigations required to establish the cause? Yeah, so we have post-transfusion tests for ABO, RH incompatibilities. We have urine tests, and we do not have a lot of transfusion reactions reported. In fact, for your record, I think the PPB website has less than 20 adverse transfusion reaction events reported. So this is an indicator that we are really, really lagging behind. And as you've rightly put it, we have massive, many transfusion reactions, but we do not have the reports. Kindly just give us the report so that we can have some sort of an analysis and get to know our blood, what kind of reactions are associated with our blood and so on. Thank you.
Yes, Stan Kish asks if we can facilitate blood donation drives and if they can get sponsors. What I can say is that KTTA is working in partnership with many NGOs, and we also have intergovernmental framework whereby we collaborate with counties in terms of mobilization of donors. We also have special groups. We have youth groups, youth forums that we use to really campaign or sensitize the population on blood. So in the case that you need some assistance, you can reach us. In case you have a group somewhere that you feel you can sensitize so that we can get blood, please, you are welcome. Reach us and then we will direct or really facilitate you.
There's another question by Ivy. Do you think that drone delivery to remote settings is feasible? This is something that we are in discussions, and once we make a conclusive decision, we may be able to let you guys know.
Yeah, there is a nice question from Brian Nyampati. It says, good presentation, but how do you address the cases of blood transfusion theft? Again, this is a serious issue of which all of us have to be vigilant. But again, as KTTA, we have the digital platform whereby all the units of blood that are donated are supposed to be in the system. And we track all the way from donation, actually recruitment, to the person who has been given that, to the patient given that blood. So issues of theft are reduced if they were there. And please, it is our responsibility as citizens to ensure that that does not happen.
Okay, another question. What would you say is the issue with relative blood donation? Any advantage of voluntary donation? As a country and as a global direction, we are moving towards voluntary blood donation. The main issue with relative blood donation is that it does not ensure sustainability of the blood supply. I can see another question. Why do people with tattoos not allowed to donate?
There's a risk of transmission of hepatitis B with the tattooing. It's the hygiene that's usually the issue and where they're done. It's a deferral for 6 months. Stopping the donor apathy due to rumors of blood being donated and sold. This has led to derailing of achieving UHC. I think more public awareness should be done. Rightfully put, Emily, I think more public awareness should be done. That is infodemics, as health promotion officers would tell you. And me and you know the truth. Unless there is evidence that blood is donated and sold, then we don't have any evidence to that.
And thank you. I think because of time, maybe I'm going to allow 1 or 2 questions. And there is one. Okay, I'll allow my colleagues to.
Okay, I can see a question by Milka. She was clarifying her previous question. The question is on recipients with septicemia and on antibiotics. Do they increase the risk of reacting to blood? So the main reason we react to blood is due to poor haemovigilance and maybe ABO or rhesus incompatibility. Those are the major reasons why we would have a severe reaction. But we would not expect them to ordinarily maybe develop a reaction because they're on septicemia or on antibiotics. Remember, most of the patients who are in ICU who are being transfused are having septicemia and are on antibiotics. As we still need more studies on this, however.
And just to add on, a patient with the septicemia who's already on antibiotics, is already being treated. There is the fear that maybe what they are getting can give them septicemia because of the transfusion transmitted bacterial infections. So it's a benefit risk analysis.
we will not deny this patient blood because they're on antibiotics. They're already being treated for the septicemia.
All right, thank you very much, our panelists, for that presentation for today. Time is very much gone and we need to end this discussion for today. So personally, I want to thank all of you, all the participants. I can see it was well attended, over 1,000 participants, and I know some were closed out, but thank you very much. I hope it was informative and that we have series of the same, and we invite all of you so that we can share our experience so that we can improve the safety of our donors and recipients in the hospital. So I want to just give 1 minute each to our speaker and our panelists in case they have some closing remarks before we end. Welcome, Dr. Gresham.
Here's a machine. Thank you, colleagues, for attending. I am sure if there are any, trying to peruse through the questions to see whether there are any unmet unanswered questions, but looks like at least 80% have been addressed. I don't see any other pending. But just to thank you so much for attending and being patient with our on and off network. Thank you so much. It's just the beginning. I'm sure we're going to address all these issues as we move on. It's a series of webinars. Kindly attend and ask all your questions. We'll be able to answer them. Thank you so much. I had said that we are all stakeholders in this. Let's play our parts. If you know you're in a position where you are involved in a blood transfusion, the pharmacists, the pharmacovigilance experts, kindly assist us to get reports for adverse transfusion reactions. Thank you.
Thank you very much, Dr. Gresham. I invite Dr. Rukia to make closing remarks.
Good afternoon, colleagues, once again. I will not make mine long because it's a Friday, almost evening. So thank you so much for attending, and I hope you have learned something. We look forward to further engagements as we have a series of Haemovigilance slides prepared for you. Thank you.
Thank you. So on behalf of KTTA, I wish to take this opportunity to say thank you so much. We appreciate your time. Let these presentations have impact in our facilities. As my colleague said, we should all be vigilant. We should all own Haemovigilance to make sure that the process is working on well. As last but not the least, we have 6 main blood banks in Kenya. That is Nairobi. We have one in Mombasa, Embu, Nakuru, Eldoret, and Kisumu. Those are the regional blood banks. But in every county, there is a blood satellite. So I appeal to all of us in this forum today that please find some time and let's donate blood and save lives. So for those many remarks, let me say thank you very much and have a nice weekend. Goodbye. Thank you.